The hospital never truly sleeps. Even at 2 in the morning, there are lights on in every wing, monitors beeping in steady rhythm, shoes squeaking against polished floors, and somewhere down the hall, always, someone in pain. For the people who work here, that sound becomes background noise after a while. Not because they stop caring, but because caring too hard every single second would break them. So nurses learn to listen differently. They learn to catch the sounds that don't belong, the rhythm that shifts just slightly, the silence where there should be noise. And sometimes, in the middle of an ordinary shift that feels like every other shift, one patient changes everything. This is the story of Margaret Osei. She is 52 years old, a high school English teacher, a mother of 3, and a woman who has spent most of her adult life taking care of other people. She coaches the debate team on Tuesday afternoons. She brings homemade jollof rice to every staff potluck. She is the kind of person who apologizes before asking for help, even when asking for help is exactly the right thing to do. On a Wednesday evening in late October, Margaret drives herself to the emergency department of St. Catherine's Medical Center. She almost doesn't come. She almost talked herself out of it twice. She sat in the parking lot for 11 minutes before getting out of the car. She tells the triage nurse that she hasn't been feeling well for about 4 days. A little tired, a little achy, some mild fever that she assumed was a cold coming on. She took ibuprofen, drank lots of water, tried to rest on the weekend. She went back to work Monday because there were midterm essays to grade and nobody to cover her class. She figured she'd turn the corner any day now. That's usually how it goes. The triage nurse documents a temperature of 38.9 degrees Celsius, a heart rate of 102 beats per minute, and a blood pressure reading of 108/68. Not dramatic numbers, not numbers that scream emergency, but numbers that exist just slightly outside the lines of normal. Margaret is assigned a bed in the main ED and is told a nurse will be with her shortly. Her nurse tonight is Diane Reyes. Diane has been a registered nurse for 11 years, 8 of them in emergency medicine. She is the kind of nurse who reads a room the moment she walks into it, who notices the small things before anyone thinks to point them out. When she pulls back the curtain to introduce herself, she sees a woman sitting upright in the hospital bed with her coat still on, her hands folded neatly in her lap, looking slightly embarrassed to be there. Diane smiles. She says, "I hear you haven't been feeling great the last few days. Tell me everything, not just the highlights." Margaret laughs softly and says she's probably overreacting. Diane tells her that people who are overreacting don't usually sit in parking lots for 11 minutes. Margaret looks surprised. Diane says the triage nurse mentioned it. They all look out for the ones who almost didn't come in. Margaret begins talking. She tells Diane about the fatigue that she initially brushed off as end-of-semester exhaustion. She mentions the chills she's been having at night. Bad enough that she woke up twice, drenched in sweat. She mentions some pain in her lower back, which she thought was from sitting too long at her desk. And then, almost as an afterthought, she mentions that she had a small procedure done about 10 days ago. Ureteroscopy, a minor procedure to remove a small kidney stone that had been bothering her on and off for months. Her urologist said everything went perfectly. She was sent home the same day with a prescription for antibiotics that she was supposed to take for a week. Diane asks if she finished the antibiotics. Margaret hesitates. She says she took them for 5 days and started feeling better, so she stopped. She figured she didn't need to finish the whole course, since she was already improving. Diane keeps her expression calm. She keeps her voice steady. But inside, something shifts into higher alert. She completes her assessment. She notes that Margaret's skin is slightly warm to the touch and a little clammy. Her breathing is a bit faster than baseline, sitting around 20 breaths per minute. Her capillary refill time is just at the edge of normal. When Diane asks about urination, Margaret admits she hasn't been going very much in the last day or so, and when she does, it's darker than usual and uncomfortable. Diane excuses herself and goes directly to find the attending physician, Dr. Kwame Asante. She finds him in the hallway reviewing labs on a tablet, and she gives him the picture concisely. 52-year-old female, post-ureteroscopy 10 days ago, incomplete antibiotic course, 4 days of fever, chills, night sweats, lower back pain, decreased urine output, heart rate over 100, pressure trending low, slightly elevated respiratory rate. Dr. Asante is moving before she finishes the sentence. He introduces himself to Margaret, asks his own questions, performs a quick physical exam, and orders a full workup immediately. Complete blood count, comprehensive metabolic panel, blood cultures from 2 separate sites, urinalysis, urine culture, lactic acid level, chest x-ray, and a point-of-care ultrasound to take a quick look at her kidneys. Margaret asks if everything is okay. She says she really thought this was just a stubborn cold. Dr. Asante tells her honestly that her symptoms are telling them there might be more going on, and they want to get the full picture before drawing any conclusions. He tells her they're going to take good care of her. For the next hour and a half, there is movement around Margaret's bed. Blood is drawn. A urine sample is collected. An IV is placed in her right arm, and fluids are started. She is given a warm blanket, and the overhead light is dimmed slightly at Diane's request, because Margaret mentioned the brightness was giving her a headache. Margaret calls her daughter from her hospital bed. Her daughter's name is Adaiz, and she picks up on the second ring, even though it's after 8 at night. Margaret tells her not to worry, that she's at the hospital just getting checked out, that she's sure it's nothing serious. She says she'll call with an update. She tells her she loves her. The labs start coming back. The white blood cell count is significantly elevated at 18,000. The creatinine is elevated, suggesting the kidneys are under stress. The urinalysis comes back cloudy, with large amounts of white blood cells and bacteria. And then, the result that makes Dr. Asante set down his tablet and walk quickly back to Margaret's room. The lactic acid level is 3.8 millimoles per liter. That number matters enormously. A lactic acid level above 2 inches, the context of suspected infection, indicates the body's tissues are not getting adequate oxygen. It means the heart is working harder than it should. The blood vessels are beginning to dilate in ways they shouldn't. The organs are starting to feel the strain. Combined with Margaret's low blood pressure, her elevated heart rate, her elevated respiratory rate, her fever, her history, and now these labs, the clinical picture has become undeniable. Dr. Asante steps to Margaret's bedside and speaks to her directly. He tells her what he believes is happening. He tells her that the infection that began in her urinary tract after her procedure appears to have spread into her bloodstream. He tells her the medical term is urosepsis, and that her body's response to that infection has begun affecting her blood pressure and organ function. He tells her this is a serious condition that requires immediate and aggressive treatment, and that they are going to begin that treatment right now. He also tells her that they are going to be moving her to the intensive care unit where she can be monitored much more closely. Margaret is quiet for a moment. Then she says, "I really should have finished those antibiotics. Shouldn't I?" Diane, standing at her side, takes her hand and says, "Right now, what matters is that you're here. The ICU team is called. The sepsis protocol is activated. Within minutes, broad-spectrum intravenous antibiotics are running. Additional fluid resuscitation is given. Blood cultures are incubating in the lab, searching for the specific bacteria driving the infection so that the antibiotics can later be tailored precisely. A second IV line is placed. An arterial line is started to monitor Margaret's blood pressure in real time, beat by beat, rather than with intermittent cuff readings. Diane walks beside the stretcher as Margaret is transported to the ICU. She squeezes Margaret's hand in the hallway. She tells her the ICU nurses are excellent and she is in good hands. Margaret nods and says, "Will you check on me tomorrow?" Diane says yes, without hesitating. In the ICU, Charge nurse Tobias Okafor takes over Margaret's care. Tobias has worked critical care for 14 years. He is meticulous, calm, and exceptionally skilled at communicating with patients who are frightened. He introduces himself to Margaret the moment she arrives, orients her to the unit, explains every piece of equipment being attached to her body, and tells her what the plan is in plain language before any of it begins. Adie's arrives within 40 minutes of Margaret's call, having driven 90 miles from the city where she lives. She is 26 years old, and she works in finance, and she is, in this moment, absolutely terrified. Tobias meets her in the family waiting area and walks her through what is happening with her mother, using language that is clear and honest and kind. He tells Adie's that they caught this at a serious stage, but that they are treating it aggressively, and that her mother is receiving everything she needs. He lets her sit with Margaret for 30 minutes before gently asking her to return to the waiting area, so the team can continue monitoring and adjusting treatment without interruption. Adie's sits in the waiting room and prays. The first 12 hours in the ICU are the most critical. Margaret's blood pressure continues to drop, despite the fluid resuscitation, falling to 88/54 at its lowest point. A vasopressor medication, called norepinephrine, is started through a central line to help constrict the blood vessels and bring her pressure back up to a level where her organs can be adequately perfused. Her oxygen saturation dips briefly into the low 90s, and supplemental oxygen is applied via high-flow nasal cannula. Her urine output is monitored closely with a catheter. Her kidneys, already showing signs of early injury from the infection, are being watched carefully to determine whether they will recover on their own or whether dialysis support might be needed. By the next morning, the blood culture results begin to show growth. The bacteria identified is E. coli, a common culprit in urinary tract infections and post-procedural urinary complications. The infectious disease team is consulted, and the antibiotic regimen is narrowed and optimized to target this specific organism with maximum effectiveness and minimum toxicity to Margaret's already stressed kidneys. Her lactic acid level, rechecked at the 6-hour mark after treatment initiation, has come down to 2.1. At the 12-hour mark, it is down to 1.7. This is meaningful. The tissues are beginning to receive adequate oxygen again. The crisis is not over, but the trajectory has shifted. Diane arrives for her next shift and goes directly to the ICU to check on Margaret, as she promised. She finds her awake, still on the vasopressor, but looking slightly more alert than she appeared the night before. Margaret sees her and says, "You came." Diane says, "I told you I would." She stays for 7 minutes because she has her own patients to get to, but she stays those 7 minutes entirely present, asking Margaret about her students, listening to the answer, laughing at the story Margaret tells about the student who submitted an essay written entirely in riddles. When she leaves, Margaret watches the door for a moment, with something that looks, just slightly, like hope. Day 2 brings gradual but encouraging progress. The vasopressor dose is slowly being reduced as Margaret's blood pressure demonstrates increasing stability. Her white blood cell count comes down from its peak. Her creatinine, while still elevated, is no longer rising. She is tolerating small amounts of oral fluid, and her urine output is improving. Dr. Asante visits on his rounds and tells Margaret and Adaz that the early response to treatment is encouraging. He explains that septic shock carries serious risks, including organ damage, and that the team will continue monitoring closely over the coming days. He is honest that there is still a road ahead and that recovery from sepsis is not always linear. But he also says that Margaret came in when she did, that the recognition was early enough, that the treatment was started quickly, and that these things matter enormously. He looks at Margaret and says, "Had you waited another day or two, we would be having a very different conversation." Margaret hears that. She holds it. Over the following 3 days, the picture continues to improve. The norepinephrine is discontinued on day 3. Her oxygen requirement decreases and the high-flow nasal cannula is replaced with simple supplemental oxygen via standard nasal prongs, and then eventually, no supplemental oxygen at all. Her creatinine begins trending back toward her baseline, a sign that her kidneys are recovering without the need for dialysis. She has started on oral antibiotics and is tolerating them well. She begins eating small meals. On day 4, she sits in the chair next to her bed for 2 hours with the help of the physical therapist, who visits and begins discussing early mobility. On day 5, Tobias writes in his nursing note that the patient is alert, oriented, interactive, expressing appropriate humor, and eager to discuss her students. He considers this a clinically significant finding. He says so out loud to no one in particular, and the other nurse at the station looks up and says, "Good sign." He says, "Very good sign." On the morning of day 6, Margaret is transferred out of the ICU and back to a general medical floor. The hallway between the ICU and the medical floor is not long, but for Margaret, being wheeled through, it feels like crossing a significant distance. Tobias walks part of the way with the transport team. He tells her she did the hard work. She tells him the nurses did the hard work, and she was just lying there. He says it's harder than it looks, to be that sick and still fight that hard, and she laughs because she knows he means it kindly, but she also knows she didn't feel like she was fighting. She just felt afraid and tried to breathe and trusted the people around her. On day 8, Margaret Osei is discharged from St. Catherine's Medical Center. She leaves in a wheelchair pushed by a patient care technician, with aides walking beside her carrying a bag of paperwork, prescription printouts, and follow-up appointment cards. The discharge instructions include a full course of oral antibiotics that she is told, very directly, and then again in writing, that she must complete in its entirety. She nods. She promises. She understands now what stopping early can cost. Diane happens to be walking through the lobby when Margaret is being wheeled toward the exit. She stops. Margaret sees her and raises one hand. Diane walks over and crouches down to eye level and says, "You go grade those essays." Margaret says, "Already texted my department head. They're waiting for me." Diane squeezes her hand one more time and stands and says, "Take care of yourself." Margaret says, "I will." She means it in a way she has never quite meant it before.